Dear moderators, ladies and gentlemen, first of all, I would like to thank the organizing committee for the invitation and the possibility to discuss this subject with all of you. When we look at goal-directed perfusion, the big question, and that's a very old question, is how do we know that a patient gets sufficient oxygen in order to satisfy his or her metabolic needs? And for a very long time, and in many cases in some hospitals even today, this was mainly done by a retrospective analysis of organ function, the blood markers, and morbidity. But unfortunately, if we maintain such a system, we are actually acting after the harm has been done. And what we are really interested in is a sort of an online analysis of risk, which actually would allow us to interact with when something goes wrong during the procedure itself. And this actually is not really new, because if we look in 1995, there was this beautiful study which was done in swine. And as you can see here, this is the evolution of the situation during the procedure. We have normal pHs, we have normal PaO2, PCO2, so it looks like it's fine. And if we look to the bypass pressures, and if we look to the central venous pressure, so there is also apparently a good drainage, and we have a very nice flow. Nevertheless, when we look at the saturation, the venous saturation at different levels in the body, then we can see that the central venous saturation is perfect. No one would complain, but nevertheless, we can see that at certain levels inside the body, apparently there is a problem or a potential problem. And it was concluded by the authors at the time that probably we should better try to match the oxygen delivery previous to bypass during bypass. But for many years, we neglected this finding. And then there is a second very important aspect. No two patients are the same. So probably an individualization of patient is an important concept. And this is now also done in the sepsis patient, and we can easily translate that to cardiac surgery. And where is PIRO standing for? Well, it starts with predisposition. A patient has a certain condition before he comes to surgery. And if we compare that to cardiac surgery, that would be he has a certain age, a certain gender, ejection fraction, glomerular filtration rate, diabetes, or eventually a redo situation. And then we have the insult. And the insult is what we do to the patient. And also that can be quite different. For example, the surgery could be a simple CABG, or it could be a combined procedure, or in some cases, it could be severe aortic surgery. We are changing the hemodynamics during cardiopulmonary bypass, and we can question how big that will result in an insult. Sometimes we need transfusion. What about ischemic times? And what about eventually the production of emboli by the system? And as a reaction on this insult, there will come a response. And the response will be translated, for example, by an increase in creatinine or bilirubin, in a decrease in diuresis, but also in the occurrence of delirium postoperatively, and sometimes with very low PaO2s postoperatively. Nevertheless, there is a normal ventilation by the mechanical ventilator, so showing there is some problem at the lung itself. And finally, and that's the most important, what do the previous three steps give to an organ? And as you can see, if we have an organ, this can lead in the worst case to an infarction. It can be a stroke. It can be the need for mechanical circulatory support or renal replacement therapy, and in some cases, even ECMO. So that means that we have two important factors. First of all, we need to define the amount of flow a given patient needs, and probably this will be dependent on the condition of the patient itself. And this is something you all know very well. As you can see here, we have a period where actually independent of the amount of oxygen you deliver, it has no influence on the oxygen consumption of the patient. But once we get in this area, you see that the oxygen consumption becomes dependent on the oxygen delivery, and this is a situation we like to prevent. And that means in order to maintain this balance, we have two important aspects: cardiac output on one hand and the hemoglobin concentration on the other hand. Now, with respect to hemoglobin and the potential effects of anemia, there is a lot of work published, and you can see here a summary of the most important work. What is important, though, is that once you go below a hematocrit of about 24%, that there is an increase of almost whatever morbidity you can think of. So apparently, anemia seems to be an important issue. But the easy part of that is that people then look to cardiopulmonary bypass and they say, well, it's mainly cardiopulmonary bypass who needs to reduce hemodilution. But this is a little bit short-viewed, as it was shown in this very nice study from Marco Ranucci, where he actually shows that if you have a patient, for example, in this case, who has a normal or a high hematocrit preoperatively, and because of that, you can maintain a very nice hematocrit during the whole procedure, then you have a relatively low morbidity and mortality in these patients. But if you have a patient who has a very low hematocrit to start with, and as a consequence of that, also a lower hematocrit during bypass, the risk is increasing tremendously. The important aspect is hemodilution is not only determined by cardiopulmonary bypass. If an anesthesiologist, for example, is giving 1.5 liters before the cardiopulmonary bypass, this in some cases is more than the total volume of the whole system. And based on this information, Marco Ranucci made a landmark paper, which is probably one of the most important papers in cardiopulmonary bypass, where you can see that in order to prevent renal insufficiency, that if you combine both flow and hemoglobin, that you should stay above a value of about 280 milliliters of oxygen delivered per square meter per minute. And this was proven indirectly by another study, which you can see here, where the comparison was made between a hematocrit of 25 and a hematocrit of 20. And as you can see, they don't see any difference, even with this low hematocrit, in morbidity. So the question then is, did we make a mistake? But certainly we didn't, because in opposition to most centers, this center is using a tremendously high cardiac index, as you can see. And if we make the calculations, you can see they stay in both cases above the critical value proposed by Marco Ranucci. So this means that, and that was the importance of the paper, that what was the message in there, that we can have a situation where we have a high DO2, high oxygen delivery, or we have a low oxygen delivery, and there will be an impact of the hematocrit. It's a small, but there is an impact. But you can see that if you have a high DO2, the risk for renal replacement therapy is much lower. But what was the main message of that? That the difference is made by pump flow. So it means that a perfusionist, when knowing this information, can actually attenuate the morbidity of cardiopulmonary bypass. And this was then confirmed by a controlled randomized trial, the GIFT trial, where you can see that especially in AKI1, there was a huge benefit of using goal-directed perfusion. And if we look now to all publications with respect to that subject, then you can see there is a risk reduction of about 2 in almost every published situation. But we have to be careful because statistics are actually showing us an average. And that means the majority of patients probably are very close to the average, but this does not mean that a single patient will precisely match those values. And that means that we have to be careful, because if we look to oxygen delivery, this is a systemic oxygen delivery, and there might be a difference at the organs. As you can see here, the kidney is much more sensitive to oxygen deprivation than, for example, the heart, and the gut is somewhere in between. That means, and this is a very nice study, if you have some time, you should really read it, that if we look to this study where in patients, they actually increased the flow, as you can see, during cardiopulmonary bypass. So they have a cardiac index of about 2.5. Because of that, they can maintain perfectly the mean arterial pressure in that patient. And of course, there is some reduction in hemoglobin because of the priming volume of their system. But the interesting part is they can maintain the systemic value perfectly above this critical value of 280, or in this case, even 300, because maybe they had a slightly higher temperature. But nevertheless, although they were where we should want to be in the systemic circulation, you can see that in the renal oxygenation, there is still an important reduction. And this is also witnessed by an increased oxygen extraction afterwards, and by some markers of kidney damage in the postoperative period. But we have to be careful, because now the simple message could be, well, the only thing we have to do is to increase cardiopulmonary bypass if we have a low hemoglobin, and that's true. We can overcome some vulnerable period by doing that, but we should not forget that also the red blood cell has some additional functions beside the carriage of oxygen. And this is shown here when red blood cells actually sense that there are regions of the tissue with a low intracellular PaO2, then they will release ATP, and by doing that, there will be a local vasodilatation. So they will improve oxygenation in this area. And that's the reason probably why we still see some benefit of higher hematocrits independently of whether we maintain DO2, yes or no. And that means that if we bring it back to the microcirculation, which are actually the organs our main interest, as you can see that we have two major deficits. One could be because the flow is not high enough, so we do not replenish fast enough the oxygen delivery to the tissue. But the other will be massive hemodilution, where it means that the oxygen has to travel a huge distance to these cells, and because of that, there will be a diffusion limitation. However, we have to be careful, because sometimes it looks very attractive to increase the flow in order to achieve goal-directed perfusion, but it's not always possible because of venous return. And the message we have here is this is an animal testing where they actually occlude or the arterial vessel or the venous vessel. And as you can see here, they have done a period where they actually have the occlusion, and then they look what happens. Now, if you look very carefully, then you will see if you have a venous occlusion that this has a much higher negative impact on the tissue than when you have a too low flow. So it means that if we increase the flow at the expense of venous congestion, that this is probably not the best way to do. And you can see it here also. The lactates are much higher on the venous occlusion than they are on the arterial occlusion. Why is that? Because we actually have fluid accumulation. That means there is again a huge distance for the oxygen to travel, and this results in issues inside the organs. But of course, we do know as perfusionists what we give. We know exactly what is the hemoglobin, we know exactly what is our pump flow, but it's also interesting to know what is the body asking from us. I mean by that, is it satisfied with what we give? And in order to do that, we can use lactate. As you all know, this is a marker of an anaerobic metabolism. And as you can see, if you have a very high lactate immediately postoperatively, then we do know that there is a higher risk for major complications. However, this factor is not easily usable because we can measure it every 20 minutes or every 30 minutes, but it means that for 30 or 20 minutes, we have to drive actually blindfolded. And that means that we can also do that through carbon dioxide because it will be converted to carbon dioxide. And we do know that under normal conditions, we have an oxygen consumption of about 250 milliliters, and we produce about 200 milliliters of carbon dioxide. That means that the ratio between the both of them, or the so-called respiratory quotient, will be 0.8. When this ratio is disturbed, as you can see here, and I will show you later an example of that, then we can say that there is an anaerobic threshold. That means that there is insufficient aerobic metabolism and that part of the body is working on an anaerobic metabolism. So how can we actually use that in clinical practice? Marco Ranucci had at the time done a lot of work on that, and he decided that the best marker was probably to use the oxygen delivery and to divide it by the carbon dioxide production, index 10 for the surface area of the patient. And the cutoff value found was around 5. And this is quite interesting because if we know that the normal oxygen delivery is about 1 liter per minute and the normal production is about 200 milliliters of carbon dioxide, then we see that this is perfectly the physiological value that we would expect. So how do we know then that the blood flow meets the metabolic need? Now, I think we can in part answer this question. We know what we give, that will be the DO2, and we know what are the critical values. And in order to be sure that this patient is actually an average patient and not an exceptional patient, we have to see what we get back from the patient, and that will be the carbon dioxide production. But there is a problem, because oxygen delivery and the calculation of oxygen delivery is relatively simple. But as you can see on the gas side, we work with the gas. And here we see not a good correlation between the PaCO2 and, for example, the capnographic values in the oxygenator exhaust. However, in another study, we see a perfect correlation between both of them. How come? Because it's important to know that air, or a mixture of air and oxygen, is actually compressible because it's a gas. And that means that we have to bring it back to a certain condition, because otherwise the volume can actually be different because of the water vapor pressure and because of temperature. So in order to have an accurate value, we need to bring it back to standard temperature, pressure, dry. And that means, and you can see that here, that if we make the correction at different temperatures, that there is a difference when we make the correction, but there is no difference whatsoever if you don't do that. And the implications of that you will see within a minute. Another important thing to understand is that the carbon dioxide production is not the same as the PaCO2, because if we have a somewhat higher PaCO2 and we increase the sweep flow, for example, from 2.5 to 3 liters, then this will go down, but it will have no impact on the carbon dioxide production. In order to control that one, we need to increase the blood flow. So how can we calculate that? I think you probably know all these calculations, so I'm not going into depth on the arterial side for the oxygen delivery, but I would like to expand a little bit on the carbon dioxide. Here you can see what a lot of people think, the sweep flow and then the capnographic value, and they calculate. In that case, it's an uncorrected VCO2 because you have not corrected for the temperature. And as you can see, in this case, it would be 105 milliliters, but if we correct it, it would be only 89 milliliters. So why is this important? Because unfortunately, companies who are selling us these machines which can do the calculations do use different formulas. And I give you here an example where you can see what is the value on the oxygenation and the carbon dioxide side. If we calculate that with a spectrum device, you see we are in a critical zone. We are below 5. But if we repeat that with, for example, a Connect system, we don't have to do anything because we are excellent in the value we would like to have. So this is a plea for companies, actually please use the same formula so that we as clinicians at least can compare apples with apples. And that means that all of this leads to the famous algorithm of Ranucci, where if the ratio is lower than 5, then you could augment pump flow while waiting eventually on blood if there is not blood available. If that's not helping, you can increase the hemoglobin content. And if that's not helping, then you can see whether you can decrease a little bit the temperature of the patient, and you can discuss with the anesthesiology the level of anesthesia. To end my presentation, I would like to show you 2 examples. This is the first example. It's a small patient, as you can see. And because of that, we can imagine also the fact that she has a low preoperative hemoglobin. So let's see what's happening. This is when we go on bypass, and we see we have a very nice DO2. We have a VCO2, which is fine, and the ratio is 6, so we are in a perfect condition. But in this center, they use crystalloid cardioplegia. And as you can see, as a result of that, we have a reduction of the hemoglobin from 10 to 8. And you can see here now we are red for all our parameters. Luckily, in this situation, the perfusionist is knowledgeable and knows what is called directed perfusion. So as a result, he or she increases the blood flow. And you can see we have immediately an acceptable DO2. But interestingly, it takes some time before the CO2 actually will come to normal, because this is the response of the body on the situation. And then we have a normal situation for the rest of the procedure. Now, what is important that if we look to the graph here, that this patient only had that vulnerable phase for about 10 minutes. If we would repeat the same, but with someone who is not aware of goal-directed perfusion and maintains the cardiac index at a fixed level, then you can see that in this case, the vulnerable phase for this patient would have been 60 minutes. And it's quite obvious that the longer you're below the threshold value, the higher will be the risk, not only for renal failure, but also for increasing of average morbidity. And this is a second case to show you that we can do even more with the goal-directed perfusion. What do we see here? We have, again, a relatively older female person. This is the calculated value at an index of 2.4. She starts also with a low hematocrit. And now look what's happening. So we start, and at the beginning of bypass, 3 minutes, we have a slightly higher VCO2. We see that the flow is higher, probably because of this, than what we normally would have calculated, and that seems to be fine. We see at the same time there is an increase in the systemic vascular resistance. And this is not actually influencing the VO2 nor the VCO2, because these values seem to be acceptable. And also the values of the ratio, as you can see, are within what we want. However, if we look to the respiratory quotient, which normally should be about 0.8, 0.9, then we see here that there is also an increase which correlates very well with the increased vascular resistance. And you can also see here how the oxygenation and the CO2 are actually growing to each other. So in this case, what's happening? Well, they actually start a vasodilator. And as you can see, they maintain the same flow. And look now, the vascular resistance going down, and immediately this is translated in a return, as you will be seeing also here, and again, a separation of the production of CO2 and the delivery of oxygen. And so we end then the operation without any further problem. When we look afterwards, you can see this patient had no increase in creatinine between the pre-value and the post-value. So what are my conclusions? GDP is actually based upon oxygen delivery, but also carbon dioxide production if you really want to have the response of the body. And an increased respiratory quotient is indicative for a disturbed microcirculation. But GDP reduces, and that's proven, postoperative morbidity. And it is the first step to a complete multivariate analysis online. I haven't discussed some of the other variables, but maybe the other speakers will, that are actually need to be incorporated. That's mean arterial pressure and autologous regulation, NIRS values, and processed EEG. But the most important thing is that with goal-directed perfusion, we can preserve organ function by influencing the host response. But in order to do that, we need continuous markers. Thank you so much for your attention.
Thank you, Professor. I want to ask Professor Andornitsis if he has any comment for this presentation. Professor.
You are muted, Professor. Can you hear us? Professor,
I can hear you.
Professor Andornitsis, can you make a comment?
Yes, you can hear me, can't you?
Yes, we can hear you now. Yeah.
Okay, fine. Thank you. I would like to thank Professor Philip de Sommer. It's always nice to listen to him. And as I was listening, I would like to have the opportunity just to share my screen for a moment, because we have some data that I would like to show some, let's say, preliminary data. So what Philip de Sommer told us is that first, with goal-directed perfusion, we will need at some point to increase the flow, okay, to keep the DO2 within the normal range, okay? So it's, let's say, a risk of congestion. And second, while performing goal-directed perfusion, we will need to transfuse because this is another way to increase the DO2. Okay, so I will try to open a file. If you will give me a few seconds, and I hope I will be able to share my screen with you. Okay, can you see my screen?
No.
Can you see a table now, or?
No, we cannot see it.
Now you can see it, I believe.
Yes.
Okay, so these are, let's say, preliminary, a little bit confidential data. I'm not sure whether I can see them very well. So what is the physiologic, let's say, how can we overcome the need for increasing flow, or the need for increasing vasodilation, or the need for transfusion? And the reply is minimal invasive extracorporeal circulation. So if you can see our data with 44 patients that we're collecting, you will see that with minimal invasive extracorporeal circulation, that we believe is the most physiologic approach to perfusion. One, you do not need to increase the flow. The index you see is lower with minimal invasive extracorporeal circulation. Two, with this flow, the DO2 index is higher, significantly higher. Three, the respiratory ratio is lower. Four, the RBC transfusion rate is much, much lower. So I would like to say that as long as we will perform goal-directed perfusion, that's true. As long as we want to perform goal-directed perfusion, the setup, let's say that goal-directed perfusion is the software. We need to have the hardware that we will, let's say, let us have the best chances of performing it without the need of vasoconstriction, without the need of blood transfusion, without the need to increase the flow. And my point is that with minimal invasive extracorporeal circulation, and we will publish all this data, we're just collecting a few more cases, this makes the environment of a more physiologic perfusion in terms of preserving what? Preserving the microcirculation, as Philippe de Sommer said, because reduced hemodilution that is attained with mini circuits, with MIEC, actually improves microcirculation. We have showed that in microcirculation studies with sublingual microcirculation. We just published a paper in Perfusion. And this, as Philip said, and as Marco Ranucci actually gave to the cardiothoracic community, improved microcirculation leads to improved end-organ protection and to reduce complication. So this is my comment. I stop sharing this data, and until we publish that, I keep some more comments for our next meetings. Thank you.
Thank you very much. Professor, do you have any other comment for
Professor de Sommer, do you want to reply to Dr. Donitzis?
Well, I think what is important is that there are several ways to go to Rome. And we have to be careful if we actually put every emphasis on a name. Because if we look over the last 15 years, we see there has been quite some evolution, both in the MIEC systems as in what is called at the time a conventional system. Today, we see that conventional systems easily, for example, in my center, a conventional system is also 600 mLs. So, I mean, both systems are growing to each other. And I think we have learned from each other. And that's important. We have learned that there are a huge number of advantages when using a mini system. But we have also seen that there are some limitations on that, which can sometimes better overcome by a more versatile system. So probably the truth is somewhere in between, that we need to combine the technology of both systems and finally merge that to an optimized system which has only advantages, but there is still a lot of work to do.
Thank you, Professor. What I want to say is I want to thank you, and we are honored to have you here in our webinar. As you conducted with Dr. Ranuzzi the most many studies, and you contributed on these values. Thank you so much.